Good afternoon. This is Mark Watt. I'm a senior consultant with the Alberta Medical Association, and I'll be moderating the session this afternoon. Welcome to the AMA Billing Update, What's New in the Schedule webinar. On behalf of the AMA board, we recognize that Alberta physicians are experiencing tremendous change and are facing an unprecedented challenge to our healthcare system, our lives and livelihood. We thank you for your commitment and dedication to serving Albertans at a time when you're being personally impacted by many changes. As a professional association, we know we are stronger together, and we are pleased to offer this webinar to provide you information and answer your questions. We know the conversation and sharing will need to continue beyond today, and we will continue to support you in this journey. Thank you for joining the session. This webinar has been approved for up to 1 MainPro credit. The evaluation link will be displayed in a web browser when you leave the Zoom meeting. By default, all participant microphones and video cameras have been disabled. Today, we'll be using both the polling and the question and answer features in the Zoom webinar. You're able to ask a question at any time by clicking the Q&A button from the webinar controls. If you're on a Windows device, this is located at the bottom of the screen. If you are connecting to an iPad, this button may be located at the top of your screen. The question and answer feature is being monitored by AMA billing experts Darcy, Marissa, and Krista, who may directly respond to your questions during the session. Questions not answered directly will be posed to our presenters during the Q&A portion of the session. We will provide a summary of the questions and responses and post these to the website as soon as possible, including questions we may not be able to answer during the session. During the presentation, you should be able to see the presentation as well as the speaker. Clicking on the tiles may change your display. Feel free to use the question and answer feature to ask any questions about the Zoom technology or for troubleshooting. Today, our presenter is Norma Shipley, Fees Consultant with the Alberta Medical Association. Please note the webinar you're participating in is being recorded. By participating, you understand and consent to the webinar being made publicly available via a link on the AMA website for an undetermined length of time. By participating in the polling and question and answer features, your name entered into the Zoom sign-in may be visible for other participants during the webinar and/or in the recording. We would like to recognize that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory and is a traditional meeting ground and home for many Indigenous peoples. In a moment, we will launch our first poll, which will open up in a new window on your device. You're invited to respond to the questions so that we have a better understanding of who is attending the session today. If you're on a Windows device, you may need to scroll down through the options to see a submit button. If you're on an iPad, you may need to select the next button to see a second question and then click the submit button. Would you please launch the first poll, please? All right, it looks like we're having some challenges to bringing our poll up. So I think what we'll do is we'll continue on. I see that we have over 1,000 participants who have joined our call today, and we wanted to thank you for your participation. We know we have members from all over the province of Alberta, and we have extended invitations to non-physician staff who are participating in this webinar today. This webinar is being provided to offer advice and guidance on recent changes to the schedule of medical benefits, including the new virtual fee codes and changes to the SOMB effective March 31. In addition to the topics displayed, we have planned for a 15 minutes of question and answer period. Please let me welcome our presenter for this session, Ms. Norma Shipley. Norma brings a broad range of experience to her work serving members as an expert in Alberta's schedule of medical benefits and fee-for-service billing. She provides education and training sessions to residents, physicians, and physician office staff on the SOMB and WCB billing. Over to you, Norma. Darcy, I'm going to give you a signal that we may need you to come off of mute to be prepared to just help continue the program along. Darcy, are you able to come off of mute?
Yes.
Wonderful. Can I let you step in and take it away while we sort out the issues with Norma's technology? As part of the CME application process, we wish to disclose that there are no financial disclosures for our presenters. They are employed by the Alberta Medical Association Health Economics branch and have no conflicts of interest to declare to the audience. Over to you, Darcy. Thank you.
Sure, thanks. Today we'll just talk about the changes that were effective March 31st, in addition to the changes for the virtual care codes. This is what we know today. So this information is changing all of the time, especially in regards to the virtual care services. And just recognize that this is information that's valid as of today. If there are any other changes, we'll make you aware of that. There are 7 new billing codes for virtual care services during the pandemic. These codes are not subject to the daily cap that was implemented March 31st. These services must be initiated by the patient, and how they do that is they can request for an appointment, or let's say you had a patient that had already had an appointment to be seen in person, and you changed it into a virtual care service. At that time, that would be considered to be a patient-initiated request, and you can continue to follow up with that patient virtually if that's what the appropriate accommodation. The referral for consultation does not have to be patient initiated. That would be initiated on behalf of the patient as a part of the referring process. And you cannot, as a physician, cold call your patients. That means you can't go through your patient roster and select 25 or 30 of your highest risk patients and call them and ask them if they're okay. If you do that, that's a wonderful service that you're providing, but it is not billable as it's not patient initiated. Many of the virtual care codes are similar to the existing codes, but there are some differences. In the virtual care environment, only the time that you spent providing services to the patient is billable. Under normal circumstances, you'd be able to bill the complex modifiers or any of the prolonged visits, consultation services. That is not allowed under the virtual care codes. You will bill. It's important to record your start and stop times in the patient record for that service and for each service that you provide virtually. If you provide a service that lasts less than 10 minutes, you are required to bill the 0301 AD code. And any other service that lasts longer than 10 minutes, you could bill the appropriate code. The patient, again, must initiate the request unless it's the consultation or it's part of the ongoing care. Again, no complex modifiers apply to these services, and neither do the business cost or the rural remote northern programs will be applied to these. You're allowed only 1 virtual care visit per day, per physician, per patient, and no additional services. So if you provide a service for an 0303 CV, for example, you cannot bill an additional virtual care service on the same day. You wouldn't be able to bill an 0305 JR or an 0301 S, for an example. And the services are not for just general COVID advice. The 0301 AD must be less than 10 minutes, and it can be direct contact by phone, video conference, or email. And it does include the prescription renewal or new prescriptions, so you wouldn't be able to bill on additional 0301 NMs. The 0303 CV is basically an equivalent of the 0303A minus that physical examination. The service must be 10 minutes or more, and it's direct contact time. So it's not 10 minutes of total care, more than 10 minutes of total care time, including charting or reviewing the notes. That includes all of the face-to-face, if you will, time spent with that patient. It is basically a limited assessment of the problem. It includes the advice to the patient and, again, the recording of the start and stop times. The 0303FV is the virtual 0303F specialist follow-up equipment. We get a lot of We get a lot of questions about this one. Why isn't my skill code recognized under the 0303F? That is another issue, but at this time, only the specialties that are listed under the 0303FV are eligible to bill for this code. It's not eligible for any prolonged services, such as the 0303FA equivalent. It's just, again, strictly face-to-face time, 10 minutes or more, direct contact, history of the problem, detailed record to the patient, again, including your start and stop times. And it's not claimable on the same day as another virtual visit. The 0308 CV is the virtual 0308A consult equivalent. All of the normal requirements for a consult still apply in this instance, so the patient must be referred, and you will make an appointment to see that patient. The initiation for the referral is basically the patient-initiated request. It's 10 or more minutes of direct contact time. It's the comprehensive assessment, history, and detailed record with start and stop times. Again, with the limitation of the virtual care, you will need to make an assessment about whether or not it is safe to proceed with a consultation virtually. You cannot claim any other virtual codes, and you do have to continue to write that referral letter back to the referring physician. As we know it, the 365-day limitation does apply to this comprehensive virtual care code, meaning that in 3 months, when you may or may not be actually to see the patient face-to-face, you could not bill another comprehensive consult. The 0819CX is the equivalent of the comprehensive psychiatric exam. Again, it requires the complete referral as a normal 0819A would. First 30 minutes direct patient contact time. That would equal the first call. In this situation, you're able to bill for additional time using the calls field. Again, they must be full 15 minutes. And unlike the other psychiatric consultations or other consultations, it's not billable for any of the other work that you would do in terms of writing that referral letter back or reviewing any of the referral letter that you received or any other collateral information that you may gather. The scheduled telephone secure video conference for psychiatric treatment. The CW is for GPs and pediatrics only at this time. We are working with Alberta Health to expand the list of specialties that will be allowed to bill the service as it is for the 0819G, but at this time it's limited to family medicine and pediatrics. Again, full 15 minutes. The CV, 0819CV, is for psychiatry and generalist and mental health. Again, FaceTime only. The services that are included in this are medical psychotherapy, prescription renewal, reassessment, counseling, and it also includes group therapy at this time. You do need to record the start and stop times in the patient record. And in addition to the requirements, the patient must have had an established mental health condition prior to just going ahead and starting to bill this. If at the time you discover that there is an issue, then you could bill the 0819CW or the CV as appropriate. All the codes are now active and in the claim system, and it can be claimed. The 0301AD was proclaimed effective March 12th, and you can go back and change any claims that you may have submitted at this time. And the other virtual care codes were backdated to March 17th. So if you haven't submitted claims for those services at this time, go ahead and start effective March 17th. If you weren't able to record your start and stop times, do the best that you can, and ensuring that your services that were less than 10 minutes or to the best of your recollection were billed as 0301AD and the others as appropriate. I see that Norma may be back.
Okay, that's awesome. Thank you. So thank you very much, Darcy, for stepping in. I really appreciate that. I'll start off talking about the March 31 changes by just saying that these changes were imposed by Alberta Health after having informed the AMA, but not had the rigorous AMA involvement in the appropriateness of the changes and so on. One thing that I will say as well is that we recognize these changes are very difficult for the profession, and they are especially difficult in the current environment where there is the additional challenge of the COVID-19 pandemic. The AMA is working on your behalf. We do raise your concerns with Alberta Health, but I will say also that this is a very challenging time to have these discussions with government. And I'm sure all of you will understand the attitudes and the thinking behind that. Could I have the next slide, please? So the first change that I'll talk about today is the change in good faith claims. From March 31 forward, you will no longer have the ability to make a good faith claim when you see a hospital patient, either in the ER or as an inpatient, who can't produce evidence of Alberta healthcare insurance. Alberta Health's commentary around that is that physicians are responsible for verifying patients' eligibility, and in the case of non-urgent problems, you may direct the patient to an Alberta Registry office to sign up or renew their health insurance. At that time that they do that, they may determine that the coverage can be retroactive. But in the meantime, you yourself or your office team may bill the patient for the services that you've provided at the Alberta schedule rates. And then once the patient has advised you that they have health insurance, you can make a pay-to-patient claim, and the Alberta Physician Resource Guide, which we can provide information about, is online, and it can provide you with information that will help you make this pay-to-patient claim. The claim submission timeline has also changed, and it's really important that you are recognizing the differences between pre-March 31 and March 31 on. Before March 31, you had 180 days to submit your claims. March 31, you now have 90 days from the date of service to submit your claim, and that includes 90 days from the patient's discharge from hospital or 90 days from the date of the last statement of assessment where you received information from Alberta Health about the claim. For claims that you make for services March 31 and before, you still can submit those within the 180-day time frame. However, if you are submitting those services for claims that are outside of the 90-day window, know that those claims will be manually assessed by Alberta Health, which means that you are in right now between a 4 and 6 month payment queue as they manually assess those claims. Alberta Health, just a reminder, will only consider exceptions to their submission timelines in case of a disaster, a fire, a flood, a theft of your patient records. They will make no other exceptions, and we have seen that in the last 6 months, they have become very entrenched in that position. There is no opportunity to appeal on other grounds. There is also, as part of these changes, a new rule about your comprehensive visits. It's important to understand this rule was not known to the AMA before we received copies of the new schedule and started to review all of the rules and other changes that were made. So this rule requires that, in addition, when you are billing a comprehensive visit, you must have had a discussion with the patient about a care plan related to their condition, in addition to providing advice, including this discussed care plan, and that all of this must be documented in the patient's record. However, now that the 0304J has been delisted, that care plan does not have to be formally signed by the patient. So all of the previous requirements in the 0304J, the comprehensive care plan, have been mitigated and no longer exist. So you don't have to have that formal signature anymore. But it's important to recognize this additional discussion of the care plan is a requirement. For those of you who practice in an office and are in one of the 7 major centers or an outlying community, those major centers we'll discuss in a moment, you will also have a restriction on the number of V category services that you may claim on a particular day. So 0 to 50 will pay at 100%, 51 through 65 at 50, and then beyond 65, those visits and other V category services will not be paid at all. So what's included in this? Any phone call to a patient, team and family conferences, communication by phone or telehealth with other physicians and health professionals, community agency communications. It's important to note for the dermatology group that PUVA has been excluded from that daily cap. A new change that, again, we only became aware of when the schedule was published is that this cap now includes home services and non-regulated facility visits. So non-regulated facilities are assisted living, designated assisted living, And that means that anytime you would go to an assisted living or designated assisted living facility to see a patient, or anytime you see that the patient in their home, or you are calling the patient from a location that you would designate it as home, that will also count toward your 50 visit cap. And that's very important for you to understand. This maximum doesn't apply, though, to rural communities, to services that you do in hospitals and long-term care, or to emergency room services. So here's the next slide, please. The list of communities is shown here. So they are each of the major centers of Edmonton, Calgary, Red Deer, Grand Prairie, Fort McMurray, Lethbridge, Medicine Hat. In addition, the outlying communities around Edmonton of St. Albert, Devon, Stony Plain, and Leduc. Airdrie is included for Calgary, and then that is the extent of those applicable communities. If you are practicing in a community outside of one of those, you will not be affected by the cap. Next slide, please. 2 codes have been deleted, and the concepts behind their deleting are different, so it's important to recognize the difference. 0304J, the Comprehensive Care Plan, has been delisted and becomes part of the requirements in order to claim an 0304A. We discussed that rule earlier that says there must be a care plan, but it does not describe the requirements of the care plan. So if you have some element of a care plan, you have discussed that with the patient, gotten their agreement, that would be the requirement for claiming an 0304A. The 0305H driver's medical for your patients that are 74 and a half and older is now uninsured. So that means that you may not claim for that service to either the patient or to Alberta Health. So neither the visit for that driver's medical nor the form completion can be claimed to Alberta Health. The AMA Guide to Direct Billing includes information that can help you with setting appropriate rates for that service. Although Alberta Health's bulletin refers to physicians continuing to claim the existing rate for the 0305H, because that service is now uninsured, you are not required to remain or to maintain your claims at the existing rate in the schedule. There are also new codes for visits that occur outside of your office. These apply to visits and consultations that occur in publicly funded facilities. However, not all visits and consultations are affected, and we'll look at the list in a moment. These are active treatment centers or acute care hospitals, ambulatory care centers, auxiliary hospitals, community ambulatory care centers, nursing homes, subacute auxiliary hospitals, and regional contracted practitioner offices. So this is quite a big list. It also includes Health Canada nursing stations. And again, this list has been compiled by Alberta Health. They are concerned, as you've all probably heard, that that there is an inappropriate, or in their minds, an overpayment of the overhead component, the facility operating component of the fee when they have funded these services in the past. So what codes are in there? Your limited office visit and prenatal visit are there. The repeat office visit or your follow-up visit for certain specialties that occur in a clinic, in a regional facility, or in your community office. Your comprehensive visit, palliative care visits, all of the group of consultations, so minor, comprehensive, obstetrical consultations, although interestingly, your repeat consultation is not on that list. Could I have the next slide, please? Also included are, for those eligible groups, the prolonged consultation payments, and for psychiatry, your major consultation, your psychiatric treatment or psychotherapy that you would typically claim under the 0819GA and family therapy are all included in that list. So from March 31st on, you would, instead of claiming 0308A in a publicly funded facility, claim 0308AZ. Alberta Health published the rates for those codes on Monday this week. And it's very important to note that only the codes that are on this list are the codes that you must claim when you are providing services in hospital. If the code that you typically claim does not have a corresponding code on the list of new Z codes, you would continue to use that previous code when you're seeing patients in any of those facilities. An example of this is 0303D for inpatient care. You would continue to use 0303D. It will continue to be paid at the rate you received previous to March 31, after March 31. Could we go to the next slide, please? So just a bit of clarification about the Z codes. There have been a lot of questions around when you would use them and how you would use them. So just a little bit about that. If the Z codes are going to be used, you must think about that as in the AHS or other facility, but not in a facility office where you have a separate facility number and the physicians pay an overhead amount to AHS for the operation of that clinic within AHS facility. AHS and the facility have to have jointly agreed and applied to Alberta Health for a separate facility number, and then Alberta Health must have granted the facility a separate number. One thing to really be clear about, though, is that in the case of people who will work in the larger hospital, so in the emergency room, on inpatient wards, even if you have that separate facility and facility number, you would still be bound once you are out in the larger hospital seeing inpatients or emergency room patients. You would still be required to use the Z codes for those services. Could I have the next slide, please? So again, any services in the ER or the inpatient ward must be claimed using the Z code, even if you have a facility within the AHS or Covenant facility that has a separate facility number. Could I have the next slide, please? So some things to think about. Outside the office facility, you still must use the Z codes, and be very clear in your mind about the location in the facility where you have provided that patient service. Could I have the next slide, please? There are also a number of DI referral changes. So imaging services prior to March 31 could have been referred by a chiropractor, physiotherapist, or audiology and been considered an insured service. These services are no longer insured. That group continues to be able to refer these services to diagnostic imaging, but patients are now responsible for the cost. Could I have the next slide, please? So I'm quickly going to go through these DI service combinations. The focus of these is limiting imaging claims in combination for particular anatomical areas. So the ultrasound for thyroid or parathyroid is now not claimable with ultrasound of salivary glands, head or neck soft tissue, or a limited soft tissue study of any site or organ. Could I have the next slide, please? X203, an ultrasound of head or neck soft tissue, may only be claimed as one call. This will include any and all soft tissue of the neck, including the salivary glands, thyroid or parathyroid. And again, it's not claimable in addition to those thyroid and salivary gland specific codes. And it does include, however, a bilateral neck mass. Next slide, please. The X311, the ultrasound, kidneys, ureter, and bladder is not claimable again with a single organ study for the abdomen female pelvis, including EV scan, or the transvesical scan for females. X315, not again with the kidney, ureter, bladder, or with the EV scan of the female pelvis. Could we go on, please? The X13, 316, I'm sorry, not claimable with the, again, kidney, ureter, and bladder, and that is a new restriction. Still not claimable with the remaining codes. Also added to that list is the EV scan of the female pelvis. Could we go on, please? X317, that's the obstetrical ultrasound. There have been new restrictions applied to that in that X324, the female pelvis ultrasound, is not claimable in addition as an additional benefit. Next slide, please. For X318 as well, the ultrasound of the female pelvis, including the EV scan, not claimable in addition. Next slide, please. X319, again, they're adding in the female pelvis ultrasound and the others to make sure that we're really focusing in on the appropriate codes. Alberta Health was very interested in the billing code appropriateness on this. Next slide, please. All right, I'm going to point you now to some resources that can help you. Next slide, please. So all of you are familiar with the AMA Fee Navigator, I hope. We are working to update the Navigator to include the March 31st codes. There are some challenges with this though, because Alberta Health has not yet shared with us the required file. As soon as we receive that required file, we will post it to the Fee Navigator. But our ability to make the changes within the Fee Navigator without that file is very limited. So we are hoping that Alberta Health will share that. As always, you can contact the AMA Billing Advice email or any of the people that you would typically contact through the AMA for billing advice. We are here to support you in this, and we will do our best to respond in a timely fashion to your emails. Although I will admit that the volume in the last week to 10 days has been very significant. So we ask for your patience, please, as we get through this. Alberta Health has published their bulletins on the usual page, and you can also, if you would like to see the full text of any of these rules or new items, look to the Alberta Schedule of Medical Benefits, and the links are posted here and will be in the slide deck that we post online for your reference. I'll turn it back to Mark.
Great, and thank you, Norma, and thank you, participants, for staying with us through some technology challenges. We'll now be shifting into a live question and answer portion. Remember, you can continue to type your questions in at any time. The presentation is being recorded and Q&A will be available on the website. I would like to welcome Darcy Shade to come off of mute and onto video as well. And as a reminder, this webinar has been approved for up to 1 Main Pro credit. The evaluation link will be displayed in the web browser when you leave the Zoom meeting. Darcy, you've been monitoring the chat. Are there any burning questions that you might like to address straight off the top?
Sure. Maybe Norma, you've already addressed this a little bit, but maybe we can go in a little bit further into with the delisting of the 0304J, and how does that work with the 0304A comprehensive visit? Can you explain that just a little bit more for our audience?
Sure, thanks, Darcy. So what we see in the rules is that there is a requirement for a care plan. The rules do not state what that care plan must include, but I would recommend that in your record of that patient visit, you note that patient A's care plan includes these steps, and that doesn't have to be an extensive list. You could have 3 steps for your care plan, for example, and then record that you've had the conversation about that care plan with the patient and maybe the goals 1 or 2 that you and the patient have agreed. That could be the extent of it. This does not have to be a large and very comprehensive care plan as you were doing when the 0304J was present. And I would just ask that people, again, bear with us as we figure out what Alberta Health's requirements are for that care plan. And as soon as we have information, we will share that with you.
That we get we're getting frequently is in regards to the ability to bill the 0301 NM physician to pharmacist prescription amendment adaptation renewal code, as well as other virtual codes. Can you explain that a little bit more?
Certainly. So when we look at the new schedule published, the 0301 AD has a very specific statement in it that it includes prescriptions and prescription renewal. So I would say that you may not claim the NM along with the 0301 AD. However, the remainder of the codes, although they say they must be the only virtual code claimed that day and the only in-person code, do not have a restriction that they may not be claimed along with the 0301 NM. So if, for example, you see the patient earlier in the morning and you use virtual technology for that visit, in the afternoon you receive a communication, either fax or phone, from the pharmacist saying that the patient is on, for example, another medication that you may not be aware of that has a potential interaction. And then you communicate either by phone or directly by fax with the pharmacist and make a decision about your prescription, communicate that to them. You could, I believe, legitimately and appropriately make that claim. Again, we have not had the involvement in the development of these codes that we would normally in previous circumstances. So our information to you today is based on what we can understand from reading the schedule and what we know about past practice. If you find that these things are not working as we have described, please let us know. We will liaise with Alberta Health to build more understanding and ensure that we can provide the accurate information that you require.
Great. Do you want me to jump in here, Darcy? I've been monitoring it well, and I see a theme of questions around patient-initiated. Could you give us a little bit more advice around some of that language around patient-initiated, and what are some of the principles that physicians should consider?
I'll ask Darcy to jump in on this as well, because we both sort of had a lot of back and forth about this between us and then with physicians. So from my perspective, patient-initiated could mean a number of things. It could mean the patient called for an appointment, or when their agent called for an appointment, and their agent could be a spouse, a family member, or in the case of a minor or someone that has a guardian, their guardian could do that. The other way they could initiate it is perhaps they had a previous appointment with you that is now being shifted into a virtual appointment. Clearly that situation is patient-initiated. In the case where you wouldn't typically have a patient come back in to discuss care results, that would be a situation, again, appropriate to claim for the visit that you would have with the patient that day. And now I'll let Darcy offer her comments.
I don't have much further to add other than to say that in certain situations where you're calling a patient to simply relay results of a test or a diagnostic, that may be more appropriate under 0305 JR. Again, as Norma said, in a situation where you would have normally called the patient in to come in and discuss those results, the other visit codes may be more appropriate, like the CV, for example.
Thanks, Darcy. Mark, what else are you seeing in the chat?
For sure. I'm seeing also a bit of a theme around providing advice to allied health providers or in long-term care. And what billing advice would you have when a physician is providing virtual advice to a team about a number of patients that might be at a long-term care facility?
That one is a challenge. And right now, I would say that they should be using the existing 0301L series of codes, LG, LH, LI, which can be used for communicating with long-term care staff, for example, about a particular patient. Unfortunately, right now, you can't use the team conference codes because those are not available when you have a virtual teleconference or a virtual team conference about particular patient populations. One of the other questions I've had about long-term care patients is if the nursing staff are taking, say, a phone or another video conference capable device around, and you're actually having that virtual visit with the patient, that may be a situation where it's appropriate to bill 03.01 AD for your contact time with that patient, as long as that is less than 10 minutes. And so keep in mind that 10-minute requirement, because that bar is very strict. And again, if you are doing that, you must make sure that you keep track of the start and end time of your visit.
Great. I am seeing, what seems to be a very popular question. So maybe we'll tackle that one. And it really is around what is the AMA doing to help support physicians in these times, helping them maintain practice viability. So maybe I'll start off, but I'd welcome your comments as well, Norma and Darcy. The one, we wanted to draw attention that the AMA is committed to providing additional education resources to support physicians, developing additional tools and supports as well. For example, next Thursday at noon, there will be a session being offered on keeping businesses viable during these times of rapid change. We'll also be looking at bringing additional information regarding what we know about other compensation models, additional information on virtual care technology enablers, and supporting clinical and team processes during these times of stress and in order to maintain practice viability. But I know that your shop is also working with supporting physicians in these times. What other advice might you have to provide?
So I'll jump in and then we'll turn it over to Darcy for any additional comments. The AMA continues to have discussions through health economics, through senior staff, through our CEO and president with Alberta Health about additional supports. We all know that the pandemic is seriously impacting your practices at a time when these additional changes are providing further challenges that make it very difficult for you. We continue to have discussions with them about mechanisms to pay physicians for their in-hospital work in very challenging times, as well as business continuation or practice continuation support when your practice ability is severely restricted based on this on the pandemic. We continue to have those. We will let you know how those are progressing when we are able to do that, but please don't think that we are not having those conversations with Alberta Health.
The next question, and I know we always look for a more satisfying answer, and I think that's kind of the state of where we are today, Norma. So thank you for sharing that. Next question, if you do an 0304A on a patient without complex conditions, is a care plan still required to bill the 04A? Is the care plan a separate document, or can it be a note just in the chart?
So based on my reading of the rule, and the specific language is very restrictive in terms of there must be a care plan, but it does not articulate what that care plan may look like. So you would need to have some element of a discussion and a notation that the patient was agreeing to these particular goals and that you were going to continue to monitor that on an ongoing basis. But it does not articulate what needs to be in that care plan.
I know that you have said that we cannot use the 0301NM and the 0301AD on the same day, but this does not seem to match their descriptions. We can only use one virtual code per patient per day, but the 0301NM is not virtual care. It is telecommunication with other health professional. In past, we would have been able to use the 0301NM or the 0301NG on the same day as an 0305JR. Why would this be different?
So for this particular situation, I realize that the description of the 0301 AD does not seem to preclude billing the pharmacy communication, but when we look down in the notes that are associated with that code, and it is important for everyone to understand that the notes are part of the description. They provide additional context about when you can use that code, and so when the notes say that it includes prescriptions and prescription renewal and so on, it makes it very hard for us to say that you could bill the NM in addition, because the NM really is about prescriptions and prescription renewal. So I fully understand your concern, and I support that. But when we look at those rules and notes, they just don't support billing the NM in addition.
Great, thanks, Roma. We have just 9 minutes left till the end of our session. Joel, if I can ask you to launch the second poll, we'll give it another try. In here, what we're interested in is understanding what topics of interest for future presentations that this group could be providing advice and guidance on. So we'll continue to answer questions and leave this poll active, but please provide some input into what types of topics you would find value in having the AMA present. So Norma, I see we have a couple of questions here around the Z codes. So I'm going to start with, why are some specialists considered exempt from the impact of the Z codes, but others who work in the hospital are not? And how will their payments not be impacted if we're being asked to submit the Z codes?
So I realize that this is a very conflicted and confusing implementation. If you look at some history, there is a little bit of rationality to the application of the Z codes. And so, for example, specialties such as emergency medicine, anesthesia, infectious diseases, in the past, because of their the focus of their work being within a hospital facility, their overhead amounts were not as great a proportion of their fee codes. And when there was distribution of allocation funding that had an overhead proportion, that proportion there would therefore have been less for those groups than it would have been for other groups with higher overhead components. So that's one of the reasons. The other thing I will say about the Z codes is that they're a bit of a pick list by Alberta Health, focusing on codes that they think are important to their understanding of the fee schedule. They're not codes that, if we had a clear back and forth and discussion with Alberta Health, that I think the AMA would have supported. And in fact, I think overall the AMA is not supportive of that particular change at all, or any of the other March 31 changes, with the exception of the introduction of the virtual care codes.
Great. I'm also seeing a bit of a theme around generalist mental health, and I know that's a common question for you. Would you mind helping us give some advice on what that interpretation should read as?
Sure, and that is a difficult description. It has deep history in the former Alberta Mental Health Board, and which was then taken over by Alberta Health Services. So generalists in mental health often are international medical graduates with extensive training in psychiatry, but who have not had specialty certification in Canada. They work primarily in Alberta mental health community clinics, or in the larger facilities such as AHS Edmonton. And they are paid in a different manner, more as a specialist psychiatrist than as a family physician who may have a component of mental health services in their practice. So they are a different group. In order to be part of that group, the criteria is first that you work in one of the community mental health clinics or in one of the mental health facilities. And second, that your own medical director supports you as someone who should be eligible for that skill code.
Great. I'm also seeing a bit of a theme in questions around good faith, and I wonder if you could, again, provide any advice or guidance around principles with good faith.
Just in regards to that, some of the questions that are coming in are, what if the patient can't prove that they are an Alberta resident? What are my obligations to that patient, and in what context do I have to continue to provide services?
Thanks, Darcy, for that. So the obligations to provide service, I would direct you to the College of Physicians and Surgeons and the CMA Code of Ethics for your guidance in that. The Alberta Hospitals Act also has some requirements around emergent and urgent services to patients who are in need. So I would strongly encourage you to look at those 3 sources for your guidance around need to provide a service to a patient in a particular situation. Remember that in your office, unless it is an emergent situation, you are always able to bill the patient directly. The criteria that you should use is this patient an Alberta resident? Do I believe they're a Canadian resident? Then you are perfectly free in either case to bill the patient directly at Alberta Healthcare Insurance rates. And then when the patient, or if they are able to come back to you, having registered and can produce evidence of health insurance, and that would be an up-to-date card, you can then make a pay-to-patient claim. But in terms of evidence that that individual is an Alberta resident, you might want to depend on an Alberta driver's license, some evidence of utility bills in their names, because of course everyone carries those around. And you will need to just use your best judgment about, does that Alberta driver's license represent a valid document for someone who is living in the province. So for example, if that driver's license has expired, I would say it's not valid.
Thanks, Norma. If we can go ahead and share the results of that poll, just so we can see what types of responses we've had to topics of interest. We'll let that come up. We are just nearing the close now, so wanted to extend our thanks to our physician members who have participated in this webinar, the AMA board for their support of this offering, Ms. Norma Shipley and the AMA billing expert team, and recognize that we have a lot of very specific questions, detailed questions that have come in through the Q&A, and that there's a commitment to responding to those questions and providing feedback through some additional billing advice. We do want to thank you for submitting those. We anticipated that there would be a lot of volume today and think that this will be helpful in getting the information out as quickly as possible. Any final comments, Norma or Darcy, before we wrap up this webinar?
I would like to thank everyone for joining us today and for putting up with our technical difficulties. And I'd encourage you to ask for advice, for billing advice when you need it. You can use our billing advice email, or I'm sure many of you have contacted individuals on the team directly, and please continue to do that. Thank you very much.
Great. Thank you all for joining today. I will conclude the webinar now. Stay safe, stay healthy. Goodbye.